And thank you for joining us. We're going to be talking about pain management with Dr. Colantonio. Doc, good to see you.
Great to see you. Thanks very much for having me.
Very excited to be here with you. There's so much we're going to go over, and we're going to start at the very beginning. Talk about your time here at Meadville Medical Center, coming here way back in the early 2000s.
Sure. So shockingly 21 years now that I've been here at Meadville Medical Center. July of 2003 is when it all began. I came here really largely because of the people that I met when I interviewed. And it was an opportunity for me to develop a practice in the way that I really wanted to build a clinic. I interviewed numerous other places. They were all already pretty well established private practices, but here it was clearly an opportunity, as administration discussed it with me. We trust you, build what you want, follow your vision, and I feel great that I've done that over the last 21 years.
Prior to coming here, where were you?
Traveled around quite a bit just because of training. So I was originally born and raised in Brooklyn, New York. So a lot of big city prior to coming here. After leaving there, lived in Washington, D.C. Spent my undergrad years there and medical school at Georgetown. And then headed off to Durham, North Carolina.
Wow.
Did my residency in anesthesiology at Duke. Finished those 3 years, and during the anesthesiology residency figured out I really wanted to do pain management as a subspecialty. Anesthesia was great, but I really missed the continuity with patients. There isn't a lot of follow-up with anesthesia. So I did a few rotations in pain management, loved it. Then went on from Duke to do a fellowship for 1 year in pain management at Oregon Health and Science University in Portland, Oregon. Spent the year out there doing that. Got a pretty random email from a recruiter about the opportunity here at Meadville. Honestly, I'd never heard of Meadville, PA, but it was again positioned as a chance to develop and build a clinic from scratch.
Were you looking more at that side of things, or were you thinking also, do I go big city, do I go more rural?
I was thinking a lot about where I was going to be able to practice. Honestly, you can find pain or any medical pathology anywhere, but where you practice and who you practice with, I think are critical. So that was very important in my consideration of where I wanted to start my practice and career. East Coast was favored over West Coast. Spending the year out there in Oregon was a good test.
So you were on the West Coast, but you were looking more towards coming back to the East Coast.
Definitely looking at coming back east, largely because of family on both sides. By that point, I was already married to Hope, my wife, and we already had our 2 children also at that point.
So when you have this opportunity presented to you, a chance to kind of dig in and start the practice that you were always hoping to start, what was that like? Was there sort of excitement with that opportunity? Was there like, okay, I got to do some research into that? What kind of went into that decision?
Good question. There was a lot of excitement about the opportunity for me to make my own bed and lay in it, if you will.
Yeah.
Like I had said before, a number of places where I interviewed, practices were already very well established. The path was set. I would sort of come in, work my way into the group, maybe eventually buy a senior partner out, that sort of thing. But I wasn't going to have an opportunity to have much input until maybe 5+ years down the road. The opportunity here was, what would you like to do from day one? And that was very, very appealing. And I embraced the responsibility as well of taking that challenge, putting my vision down, and executing it. And thankfully, that's worked out extremely well for a couple decades now.
So let's talk about those early years. What were sort of the focus areas, and how has that grown?
The focus areas initially were just getting the word out about who I am, what I'm able to do within the practice. I brought a lot of new therapies here, largely because of my fellowship training. Anesthesia is one of a few fields that can prepare you extremely well for pain management as a subspecialty. In anesthesia, we have a lot of experience with interventional techniques, procedure-based things. So I was able to bring a lot of those new things here in 2003 when I started, complementing that with a lot of pharmacology, so management of medications for patients. And the focus was a balanced practice, offering interventional techniques as well as some pharmacotherapy to assist our patients. After that, it was how do we expand the practice, how do we grow the staff. We've grown at this point from just having maybe 4 or 5 staff members to a dozen.
Wow.
In the clinic at this point. So we got over that hurdle of growth. We had a couple bumps along the way. Just a few months into my start here, we had a flood at the basement of Grove Street, where the clinic is still located. That displaced us for about 6 months, but it also was a bit of a blessing. It was an opportunity to remodel the entire clinic. So we got the flow through the practice optimized for patient visits, as well as getting the procedures performed for folks.
So when it comes to your vision, I mean, really, even from the design of your workspace, so to speak, you've really had full input on this.
I have, and that is what I'd hoped would happen with the opportunity here, and I don't believe I would have had that opportunity to have structural input for the brick and mortar part, nor the type and style of practice being balanced with interventional procedures, with pharmacology, with supportive psych services for counseling. All of those elements are very important, managing and helping pain patients. So we were able to, fulfill the vision of balancing all of those modalities in what we offer.
Let's get into the specifics and kind of pick up where what you were just talking about. When somebody hears pain management, what are they normally thinking? What should they be thinking? Talk about that range.
Yeah, another good question. You're good with these questions. So I think, honestly, if you ask 10 different providers or even patients, what is pain management, you'd get 10 different answers. To me, and I think culturally to my staff, we approach it as an opportunity to help patients regain a point of control of their pain, so they regain a point of control on their life. Our patients, their pain patterns affect their activities of daily living significantly for the negative. So the goal is to help reduce that burden for them. We don't really realistically talk about resolution of their pain. To be honest and frank, that's rarely achieved in chronic pain conditions. The goal is control it over an extended period of time. A lot of the conditions we treat, they're not going anywhere. They're going to linger for patients, musculoskeletal conditions, nerve injury conditions. They're not just going to disappear. So pain management for us is getting their quality of life improved and achieving that through a better point of control of their pain patterns.
Kind of give us sort of that generic patient that's coming in. They're coming to you and saying, "Doc, this happened." You know, what are some situations that are occurring that people are coming in and saying, "I'm really suffering"?
The vast majority of our patients are coming in with some form of musculoskeletal spinal problem, whether that's their neck, their thorax, or their low back. That could be a disc herniation, something that's acute for them, or just a degenerative problem over time. The vertebrae along the spine just start to become a bone-on-bone situation, the way you would see in a bad arthritic knee. That causes local joint pain and problems for them. It also can start impinging or pinching on nerve roots that are trying to leave the spine. So that's our most common patient that will come in, is a spinal condition that's bothering them and limiting their activities. Arthritis, spinal stenosis, Those are our most frequent folks. The other large population I would classify as nerve injury patients. So there are conditions that are called neuropathic pains. So we see a lot of diabetics that have nerve injury from really high sugar levels in their blood over the years. Sugar is a toxin, actually, to nerve endings. It melts away the normal coating, and they end up with essentially what would be an exposed, non-insulated wire
Wow.
at their nerve endings in their feet and their hands. Extremely painful situations. So those types of nerve conditions are the other large subset of what we would normally see.
I'm sure you've never heard this. Yeah, I kind of felt this pain years ago. I should have taken care of it then or had that conversation, but now it's affecting my life. That's why I'm here to see you.
Yeah, very, very common piece of the history. There's very few patients that haven't had some 10-plus year history
Wow.
with their back pain. Many will say it started way back when. But to your point, over the last 6 months, 12 months, this has really interfered with quality of life, whether that's vocational and or social impact. We certainly see both.
Yeah, and this is an area where, from tool and die to the way folks like to go out and take part in sports, recreational opportunities, there's a real chance to abuse the body and think, I'll deal with it later.
Absolutely true. We are very sophisticated machinery, and parts wear down and parts wear out. And in an actual machine, you just kind of pop new parts in, right? Or you spray some WD-40 on it and things are working a lot better. But in the human body, it's not so straightforward to pursue those interventions.
So a lot of times you're trying to figure out, okay, how do we manage this? How, what's the path? And
Correct.
having those conversations with your patients.
And many of them are hopeful the path doesn't involve a surgery. So we do share many patients with our local surgeons, Dr. Gasibi in particular, as our spine expert here and spine surgeon. And there will be patients that come in asking for a fix. And we counsel them. What I'm able to do with my capacity will help reduce the structural problem that's there, and we might be able to control this over the long haul without a surgical intervention.
And that's the first step, right?
There are precursor steps actually before a patient would get to my clinic. Many of them will have taken ibuprofen, Aleve, Motrin, some form of an NSAID or a non-steroidal anti-inflammatory drug for months. They'll go to the chiropractor, they'll have been through physical therapy, so a number of other conservative modalities usually have been tried before they arrive to our door. And some of that is understandably their primary care physician or their eventual referring doctor is being cautious as they step through a treatment plan. But also, this is a separate topic, but insurance drives a lot of what decisions can be made these days. And there are many things that we do that we can't do for a patient unless they have gone through all of those other precursor steps.
Let's kind of touch base on something known as the decade of pain, and then let's talk about
Long gone.
long gone.
Yes.
But maybe just touch upon that real quick, and then how much has changed since then, and what the future looks like.
Yeah, to me, there's been tremendous change since I started 21 years ago, and when I started, that was in the midst of the decade of pain from 2000 through 2010. That was a decade when pain was championed. Every provider was encouraged to address it adequately for their patient that came in complaining about pain. In fact, during those years, pain got implemented as a fifth vital sign. So along with heart rate, blood pressure check, oxygen level, and temperature measurement, every time you're presented to an office, hospital, emergency room setting, the provider was required to ask your pain level on a scale from 0 to 10, and that was included with those other 4 vital statistics. So pain was considered a vital statistic at that time. It still is today, but more of what's changed has to do with the war on prescription drugs, which began 5-6 years ago now in heavy fashion. And I'm sure many folks that will watch this are familiar with everything that's come out about OxyContin and Purdue. Unfortunately, very crippling for the pipeline of medications that are available to us in this discipline. There haven't been any new medications, especially in an opiate category, that have come out in years. And most of big pharma is about a 10-foot pole away at this point from having anything in their pipeline that they're offering now to us as another tool in the toolbox, if you will. We used to have reps coming by every couple months with medications coming out, some opiate, some non-opiate. That's all dried up at this point. And I think, unfortunately, it's just fear from these companies of putting something in an opiate class in particular out there, and then undergoing all the scrutiny by the FDA, by the DEA, by other agencies, and then eventually having to pull it off the market.
Does that mean going back to the toolbox and sharpening those other tools that you have? And what does the future look like?
It means sharpening tools we already had, and it means putting new tools in the box, at least for me. So our practice has, by necessity, evolved a lot over the last couple decades, and especially over the last 5 to 6 years, as we have not had a lot of pharmacology brought to us as an option anymore to help treat patients. So there's been more of an emphasis on the interventional side. Device companies are coming out with a lot of things to offer, but those are fairly invasive. But that's been more where the local activity has been over the recent few years, away from drug and more toward device.
Before we get into some personal questions, what are some things maybe you want your patients or potential patients to know about your practice?
I would love them to know that we take extreme pride in spending time with our patients and ensuring that they understand what is actually going on with their condition, that we're going to then talk about trying to treat and keep under control. I have more than 50% of my patients arrive very little to no understanding of what is actually wrong and what we're going to address. So that's hugely well received, and we get comments, fortunately, on that all the time, thanking us for helping them realize what's happening. So we spend a lot of time with our patients. If there is a complaint at my clinic, it's usually that I'm running late because I spend a lot of time with our patients. I'd like them to know we are evolving out of necessity, in part because of what I said earlier, but also there's literature emerging now that there are ancillary services, procedures available, adjunct therapies to provide patients. And we're leveraging my 21 years of experience in this and observing how patients have responded to things that are standard or routine or covered by insurance versus moving to some new things like medical cannabis, certain nerve blocks for neuropathies, neuromodulation therapy. So we're really trying to be proactive in our evolution, but always doing that with the utmost safety for our patients.
Should somebody contact your office directly or work through their primary care physician?
Yeah, so we're referral based. Again, a lot of that is insurance driven. So most providers are familiar with the process, but for those that are not, we have internal referral mechanisms through our electronic record here at Meadville Medical Center. Anyone outside the MMC network can fax anything over about the patient with a referral, and then we review that, we get in touch with the patient, move them forward toward an initial consult with us.
This has been a fascinating conversation, and there's so much more we could learn, and we'll have to pick up on this. But I want to ask you, coming from a big city, what were some of the surprises about living here in rural Pennsylvania?
How nice people can be was one, and courteous, and that you could, most of the time, not worry about locking your door every single time you left your house. I specifically remember that struck me the first week we were here. When we left our house, everything was lock and key, and our neighbors were looking at us like, we had three heads. So what are you doing? You don't have to worry about that. I'm like, what do you mean I have to worry about that? Yeah, those were some adjustments that had to be made. But from a family standpoint, I couldn't think of a better environment to have brought up my kids. And to have time in a community hospital setting, again, all kind of goes back to pulling through the vision of what practicing responsible, high-quality medical care is all about. And I've been at many large academic institutions in big cities. It can be a cattle call of 60, 80 patients in a day. This bit about, you're going to run a little late, that's okay. That doesn't happen in those environments. It's just not tolerated. So those things have been special, honestly, about the community here, and I think that's all baked into a small town culture.
Not a number, but a name.
Correct, a name. Yep. We have, in my clinic, we have still photographs of our patients. Of course, they consent to that, but we used, before all these electronic pictures, we had old Polaroid shots. Every one of my patients had a Polaroid shot.
Wow.
At their first visit, and that went into their paper chart. And we still keep paper charts to this day. That's how old I am. And some of that is backup, honestly, just in case something happens with AI. And we've had that instance here a few years back, coincident with COVID. We didn't have access to our EMR for weeks. And that didn't affect us at all. I didn't miss a beat. We had everything we needed in old school paper charts.
Wow. At the end of the day, what do you do to relax?
Golf is pretty much the getaway. Yeah. Can be a great game, can be a super frustrating game. I guess that's part of the draw of it. But I enjoy me against old man par and just being out there in the open. So that's a big part of the escape.
And for your family, we live in an area where you're not that far from a big city. You can get to Pittsburgh, Cleveland, Buffalo, New York, Chicago. So it's kind of the perfect place to be.
Yeah, truthfully, that was talked about when I interviewed here all those years ago, proximity to Buffalo, to Pittsburgh, to Cleveland, and we have done that for sure. D.C. is not an absurd ride either. It's only about 5 hours trip. My daughter is down in that area now at PA school, James Madison, so we're there almost monthly on a weekend, getting to visit her. And that more than fills the big city need, if you will, at this stage for us, for sure. And I don't miss, I appreciate having grown up in New York City, but I would not move back or even try to raise a family there. I don't know how my parents did it.
We have pretty good bagels around here too.
Yes, yeah, we certainly do, and pizza.
And pizza, absolutely. Doc, thank you for your time.
Sure, yeah, you're welcome. Really enjoyed it.
And we thank you for joining us as well.